Hi everyone, my name's Fraser. I'm currently in 6th year and I put my hand up to do the Burns lectures for you guys. So this is basically just going to be a crash course in Burns. Hopefully you're watching this pretty soon after your Burns case, so should all be pretty fresh. But if you're watching this in swap vac or even the night before your exam, hopefully this is helpful to you. I'm going to try and cover all the sort of really relevant stuff to your exams and stuff you might see come up. In terms of what I used Anatomy and Physiology book. I used Saladin, the Unity of Form and Function. I also used Up to Date, and this is also going to contain just things I remember learning at the time in 3rd year and that I found helpful and stuff that came up in exams as well. So let's start. So in terms of contents, I'm basically going to cover your skin anatomy and physiology at a pretty basic level. I'm going to talk about what is a burn, and I'll also just have a few self-assessment questions at the end, just 3 of them, and share with you the resources I used, which is essentially what I mentioned before. The aims are just to have a basic understanding of the skin and burns physiology and know the must not forget rules of burns. So basic anatomy and physiology of the skin. Well, it's the largest organ in the body and it's the heaviest organ. So it covers around 1.5 to 2 meters squared and accounts for 15% of your body weight. It averages between 2 to 3 millimeters, with the thinnest being the eyelids and the thickest said to be between the scapulae. But some would argue that it's the feet and hands that are the thickest, but that kind of skin is also different. It's known as glabrous skin, meaning that it's devoid of hair, and it adheres really closely to the subcutaneous and fibrous layers. Essentially, the function of that is that it doesn't slide around. One of the concepts that I found really useful when thinking through this case is knowing that form equals function. So here's a slide here of the gross anatomy of the skin, but I'm not going to go through every label here, but the things I want to point out is that you should know where the nerves and structures sit. This is important clinically for burns, especially in terms of burns that are painful versus non-painful burns. And then knowing these blood vessels here. So the position of the blood vessels is important because you have superficial blood vessels and deep blood vessels. And this helps with heat preservation and controlling your body temperature, which once again, you can imagine if you lose this ability is really bad when you've got a burn and you lose it. So now looking at the histological level, before I go through some of these forms or structures that equal function, just one of the things I want to point out that has come up in exams is sort of knowing your layers of the epidermis. The way I've always remembered it is with the saying, come, let's get sunburnt. So going from superficial to deep, essentially it's stratum corneum for C, stratum lucidum for L, stratum granulosum for G, stratum spinosum for S, and stratum basalis for B. Just to point out the meaning of it, so stratum corneum basically means the horn layer. As you can see, it's got these little projections here of the dead cells coming up. Stratum lucidum is the lucid layer, and it's quite clear. In the stratum granulosum, you can see as the nucleus sort of breaks down, you get all this granular material within the cell, so it looks quite granulated. And then there's stratum spinosum, which is due to these tight junctions and the shape of the cells as well. And then here's the stratum basale, which is just, I guess, the most boring layer. It's just the layer that sits along the base layer. So now going through the functions. So you can see on the epidermis, you've got this layer here and the sebum that's secreted onto the surface of the skin. And sebum contains proteins and chemicals and is also quite acidic with a pH of 4 to 6, meaning that bacteria can't really grow very well in it. Then you've got sweat pores, which also help with thermoregulation. Then obviously there's the dead keratinocytic layer, which sloughs easily. It's a barrier for infections and chemicals and trauma. And then you've got immune function within the skin with dendritic cells, which you'll remember from MMI in 2nd year, help with epitope sampling. So they sample the external epitopes in the environment to give you a good repertoire of antibodies against the external environment. Then you've got melanocytes, which help with UV radiation or protect you from it. And then there's tactile nerve fibers, which obviously are there for sensation. You also have pain sensation, pressure, vibration, all of that, which help to protect you. And then there's tight junctions, which act as a barrier to water and other substances. Not only does it stop water from going into your body, but it also stops water from leaving your body. Just to summarize all of that, the skin has a lot of functions. And just to summarize, so it's protection against trauma, infection, UV radiation, and chemicals. It stops water loss and water absorption. So if you sit in your bathtub, you don't absorb all your water. And it's also got hormonal activity such as vitamin D synthesis. Obviously sensation as well, and thermoregulation. And then the immune sort of side as well. And one of the things that doesn't really come up a lot in your physiology textbooks, but is also incredibly important, is that skin helps with nonverbal communication, your facial expressions, your emotions. And it's also got an aesthetic side as well, which is a general indicator of health. If you think about it, all your physical exams, you start with general inspection, and often you comment on the person and the way they look, and such as if they look flushed, pale, things like that. So it's very important. As you can imagine, if you get loss of the architecture of the skin and the form of the skin, you then lose the function of the skin. And this is incredibly important with burns. So what is a burn? So I went looking for a definition, and I was hoping to find something quite succinct, but really it's quite a broad definition. So in UpToDate, they define burns as a result from traumatic injuries to the skin or other tissues, primarily caused by thermal or other acute exposures. Burns occur when some or all of the cells in the skin or other tissues are destroyed by heat, electrical discharge, friction, chemicals, or radiation. Burns are acute wounds caused by an isolated, non-recurring insult, and healing ideally progresses rapidly through an orderly series of steps. In terms of the epidemiology, I had a look at the Burns Registry of Australia and New Zealand, and this is the 2018-2019 report. So in that time period, within a year, there were 3,281 patients admitted to a burns unit. That's not to say that's the total amount of burns that occurred in that time frame. It's just to say these are people who were referred to a unit who needed specialized treatment. The average age was 30 years old, with 67% of them being male. Once again, that's not to say males are a risk factor. It's just that in that time period, majority of them were male. 33% of adult burns were due to flame, 56% of pediatric burns were due to scalds, 3% of burns were self-harm. 29% of children did not receive adequate burns first aid, which I found quite interesting. And 10% of patients with a burn exceeding a total body surface area of 20% died. So it is quite significant. In terms of the etiology, as you can see, there's lots of different etiologies for burns with heat, radiation, electrical, and so on. And I came across friction burns, and I didn't realize this was such a common thing. And I went looking into what they meant by that. I came across treadmill burns, which are apparently pretty severe and have their own guidelines on how to manage them. In terms of classification of burns, there's 3 things that you need to know. You need to know the total body surface area percent affected, and you need to be able to know the full thickness and overall area that's been affected. And for you to know that, you need to know how to calculate the depth of a burn. In your studies, you've probably come across 2 systems. You'll come across an older system, which is the 1st, 2nd, 3rd, and 4th degree burns. And then there's a newer system, which is the superficial to full thickness burns. You also need to understand and know the location and distribution of burns. So for example, circumferential burns, burns involving the mouth, nose, hands, joints, genitalia, etc. These special areas, it's really important to know where the burns are. The reason being is that a 1% burn on the forearm is managed very differently to a burn on or around the mouth or genitalia. When you read about total body surface area percentage of burns, there's probably 3 methods that you'll come across. and that's going to be the Lunt and Browder chart, the rule of nines, and the palm method. Now, each has their advantages and disadvantages, but if you are asked which is the most accurate way of measuring, you're going to say Lunt and Browder, especially in children where their head sizes tends to be disproportionately large to their body. But then say you're an ED and you're asked to calculate something, or you've got an exam question and you're asked to calculate it and you're not given a chart, you're going to use the rule of nines. The palm method is most accurate with smaller burns, but you wouldn't use it for large burns. And just so that you've got it for your notes and can see what it looks like if you haven't seen it, this is the Lunt and Browder chart. As you can see, there's a pediatric one and it goes all the way up to adults. And then there's the rule of nines, which is sort of your quick assessment tool that you might do in ED. In terms of depth, I've got this table here. Personally, I'm not a fan of tables. This doesn't really help you identify the depth. It kind of is just for academic reasons. But you can see that there's the different levels of depth that it mentions. And ignore this for now, because I will talk about it in the next slide. But the important things, I guess, here to note are the sensation, the fact that epidermal is quite painful. And then as you go through deeper and deeper, they become less painful as you've burnt away the nerve endings. And then healing time is also important. As mentioned in the definition, they tend to follow a pretty predictable path to healing. And this is what it means by this. Usually at certain depths, you get certain time frames of healing. So this is a burns depth assessment algorithm that I found from some really old notes that someone presented to me in third year. But one of the things I wanted to point out is it mentions, is it slippery? The truth is that if you're given an image, you're not really going to know, is it slippery or not? But essentially this translates to, is there a blister or not? And you've got to ignore the circumference and focus on the central area of the burn. And I've got an example later on. But just to step through it so everyone's aware. So when you look at the burn, if you can see the epidermis, so basically you look at the area that's not burnt and the area that is burnt. And if there's epidermis present, well, then it's an epidermal burn. But the other thing to do is you need to be able to touch it and slide your finger across it to confirm the integrity of it. So Nikolsky's sign is when you slide your finger across the burn and then the epidermis lifts off the dermis. If that happens, there's no integrity, meaning you go straight to no. And then the other thing you can do is you then say, well, is it slippery? Or you say, is there a blister? And so if there is a blister, you go yes. And in this chart, it's broken it down into superficial and mid-dermal, but I would just ignore that. Essentially, it's the same thing. And so you say, is there a blister? Yes, well, then it's superficial dermal. If there isn't a blister, you then look at the color. So then it's easy. You just say, is it red or it's deep dermal? Is it white? It's full thickness. And just to visualize it all and put it all together and to compare it to the 1st to 4th degree method, you can see you've got your layers of skin, and then you've got your epidermal burn, obviously doesn't cross into the dermis. Then you've got your superficial partial thickness, which goes into the dermis, but probably doesn't pass the halfway mark. Then you've got your deep partial thickness where you pass the halfway mark, but you're not at the subcutaneous level. Full thickness, you have no dermis left, it's at the subcutaneous level. And then you've got your deep burn injuries where that's the easiest probably to assess because you see muscle as deep burn. Then I mentioned location and distribution is crucial. And the reason why that is because you need to know if you're going to refer them to a burn center. The other reason is, as I mentioned before, if they've got circumferential burns, they're going to need special surgeries, so escherotomies. If they've got large surface areas, they're going to need grafts or reconstructive surgery as well. And then the other really important thing is if there's any airway involvement, you're going to get anesthetics involved. And interestingly, there's not actually many specialist burn centres in Australia, though in South Australia, we're lucky because Royal Adelaide and Women's and Children's is, but these are all the burn centres in Australia. So then you have to ask yourself, when does a burns expert need to be involved? So I've got a list here of the reasons why you would refer someone. But the things I just wanted to point out and things I remember coming up in exams or OSCEs and things like that, and this is from 3rd all the way to 6th year or 5th year for exams, is burns greater than 10% total body surface area, burns greater than 5% in children, any full thickness burns greater than 5%, and burns in special areas, and of course your burns with inhalation injury. These are the things I remember coming up in exams. Though I would recommend you know all the others as well. I'm just pointing that out to you. In terms of burns management, you can never really go wrong if you break your management up into acute and chronic management. And then the other system to break things up into is your non-medical, medical, and surgical. But in this scenario, I'm going to talk about acute versus chronic. To understand what you're going to do for an acute patient, you really need to understand the sort of aims of it. So the aim of acute management is to stabilize the patient and reduce the risk of further harm. Now I've got a list here. I know it's long, but I'm going to just point out the main points. So essentially everyone should know that you do doctor's ABC. You also need to stop the burn as well. So it's and a general first aid rule is that you run cool running water over the burn for 20 minutes, but that's obviously dependent on the scenario as well. You remove clothing, jewelry, and essentially anything else that could be an infection risk or could constrict the burnt limb, such as rings around the finger, as when swelling sets in, obviously it's going to constrict. You need to protect the airway. As I mentioned, any hint of airway involvement, get anesthetics involved and intubate. You need to maintain perfusion. So that's where probably the key word here is Parkland formula, which I'll talk about in a bit. And monitoring urine output is really important to know if you're giving them adequate perfusion. Analgesia and sedation. People are either going to be in really severe pain or they're going to be so shocked, and for you to do everything to them, you're going to need to sedate them. Involving burn specialists, this is really important, and that's why you need to know your referral criteria. And reducing the risk of infection. So sterile dressings, good hygienic environment, and understanding some of the physiological changes that happen during burns with, say, translocation of gut bacteria into the bloodstream. And having an understanding of the organisms that you'll get in the time frame you'll get them. So as a general rule, within the first 2 days, so 48 hours, gram-positive bacteria such as Staph aureus and your group B streptococcus such as Strep pyogenes become common. From days 2 to 21, you start to see gram-negative bacteria. A particular one that's mentioned often is Pseudomonas aeruginosa. And a key with it is that's often described to have blue-green pus and a grapefruit smell. Though I do remember a lecturer saying it was more of a caramel smell, but essentially a sweet smell. And then later down the track, you start to think of your fungi and complicated earlier infections. Understand that when someone has a burn, their calorie requirements go up and you need to be able to feed them because they might not be able to eat, especially if they're sedated. As a general rule, the 2 ways you can give people nutrition is you can give it through their veins or you can give it through their gut with, say, like a nasogastric tube or an enteric feeding tube. The other general rule here is that food was never really made to go in your veins, so you should always opt for putting it down into the gut when you can. Try to prevent rhabdomyolysis. Usually there's a lot of trauma to underlying muscles and tissues, so you're at risk of renal failure and impaired renal function. And basically the only treatment you've got is to just resuscitate them adequately. Controlling the body temperature, really important. You lose your skin, you can't control your body temperature. So you need to give warm IV fluids, warm room air, and warm air blankets. The other side of things is to remember your VTE prophylaxis. They're probably going to be bed bound, so they're also at risk of pressure ulcers. So you want to try and avoid losing more skin by making sure they don't get pressure ulcers. Also remember that people who go for these massive stress responses of burns can often have decreased blood flow to their gut and things like that, and it puts them at risk of stress ulcers in the stomach as well. So Parkland formula, I mentioned this was a key word and it's really important in burns. So the Parkland formula is total body surface area percent times weight times 4 mil. That will give you your mil per 24 hours. The other key here is you need to know that you give the first half in the first 8 hours from time of burn, and the rest is given over the remaining 16 hours. Just as an example, if you've got someone who's got 20% body surface area burnt, they're a 70 kilogram person, you're then going to times that, I believe it equals 1400 mil. You times it by 4 mil, you get 5,600 mil in 24 hours, and you give the first half in the first 8 hours. And that's from time of burn. So if they arrive, for example, 5 hours after the burn, you have 3 hours to give the first half. I also just want to note that the Parkland formula is generally used for large burns and people with ongoing maintenance as well. You need to calculate that, but it's obviously case specific and depends on the team. Generally, urine output is your best measure of perfusion. So you want to get a 0.5 to 1 mil per kilogram per hour, and that indicates adequate perfusion to the kidneys, which indirectly suggests adequate perfusion elsewhere. And the other thing that you need to note is that you don't use normal saline, you use something like Hartmann's solution. And I've also come across articles saying you use Ringer's lactate as well, but Ringer's lactate has a similar composition to Hartmann's solution. Just also note that in burns, you normally lose your plasma volume, not really blood. They don't tend to bleed, it's more just the plasma that you lose. So resuscitation's really important in burns. It's not just because you need to keep them hemodynamically stable, but it's also because it helps with the prognosis of the burn. So in burns physiology, as a general sort of rule, you have 3 areas. You got your zone of hyperemia at the boundaries. You got your zone of stasis and the zone of coagulation. Now, the zone of stasis is potentially salvageable, but the zone of coagulation is not salvageable at all. So if you adequately hydrate them and resuscitate them, you can salvage that area and you've just made the zone of coagulation smaller or at its most minimal size. Where if you don't resuscitate them properly, you're just going to make the burn worse. There's more unsalvageable area. They lose more skin, more tissue. Now for chronic management, you need to understand the aims as well. So the aim is to return to a functional, emotional, and mental state at or as close as possible to prior to the burns injury. I remember in med school, they drummed into us a lot about holistic approaches and knowing who's on the team, who's involved. And it is incredibly important because this is a holistic process. I've listed it here for you. So essentially physiotherapy and rehabilitation, you're going to have physiotherapists, rehab doctors, nurses. Occupational therapy, you're going to have occupational therapists. For psychotherapy, you're going to have therapists, psychiatrists, psychologists. And for skincare and maintenance, you're going to have physiotherapists, dermatologists, burns nurses. Financial and social circumstances, you obviously have social workers. And for skin grafts and further surgery, you're going to need surgeons, and that could be plastics, orthopedics, burns, and cosmetic. Another really important area is understanding skin grafts. So it's quite complex, and I've summarized it as best as I could. Essentially, you've got split skin, full thickness, and synthetic. As a general rule, full thickness is good for face and special areas and is cosmetically better than split skin. But split skin takes better to the area that you donate it to, but it's not really good for super deep burns as it relies on you having the dermal papillae present. Also just want to note the difference. You might come across auto, allo, and xenografted skin. When you talk about allograft, it's skin that's from the same species. So cadaveric skin transplants are possible. I read about xenografts, but I couldn't find a lot about it. But there have been some studies or some people who've tried to use pig skin as a xenograft. And then there's autografts, which are from the same person. So here's a table that summarizes the key differences between split and full thickness. Just to quickly go through it, your thickness, your split is obviously thinner. It's usually epidermis plus minus dermis. Full thickness is epidermis plus dermis and sometimes subcutaneous tissue. Donor areas, splits can be taken pretty much anywhere where there's normal skin and then transplanted. But full thickness, you tend to go for what are called flaps. So you might have a burn on your shoulder, but normal skin below on the arm. So you might make an incision on the arm to release some skin, flip it around to create a flap, sit it over the shoulder, and then suture up the lower arm. In terms of healing, you get epithelialization with split. We get primary closure with full thickness. The split skin tends to take easier to the new site, where full thickness, it's not good for granulating or healing wounds. It's one of these things where you'd put it over fresh underlying tissue. In terms of contraction, as a general rule, split contracts more over time, where full doesn't. And full thickness has better cosmesis with normal color, where split becomes hyperpigmented over time. In terms of resistance to trauma, they're both not brilliant, but split has poorer resistance, where full thickness is better. And in terms of hair, full thickness will eventually grow hair and have the function it originally had, but split thickness won't grow hair. As a general rule, split thickness, better survival, but more fragile and doesn't resemble original skin. Full thickness has better function and cosmesis, but poorer survival. Now, I've mentioned a lot throughout this lecture at this point, and I just want to clarify the key things that I think you should know from this case. You should know doctor's ABC. Everyone should know that. You need to know that if any airway involvement is present, you need anesthetics and to intubate them. There's this thing, I didn't mention it earlier, but it came up one time during an exam, and it was a patient who fell in cement. So cement can cause alkalotic burns, so be aware of that. With electrical burns, they tend to have an entry and exit site, and they tend to also have internal injury as well. So you also need to think of things like whether they've got an arrhythmia from being electrocuted or internal injury as well. You need to know the Parkland formula, and to know the Parkland formula, you also then need to know how to calculate total body surface area percentage, and also understanding the basic skin graft differences, which I mentioned in the previous slide, and knowing your referral criteria. So now, just to finish, I've got 3 questions. So of the patients below, which ones meet referral to a burns unit criteria? A 1-month-old infant with a 1% burn on their forearm, a 6-month pregnant woman with an open flame burn on her forearm calculated to be 3%, a 26-year-old male with a deep dermal burn on his outer thigh calculated at 4%, a 40-year-old construction worker who fell in cement, a chef who scalds his hand and inner thigh calculated to 6% mixed deep dermal and superficial, and a firefighter who is exposed to a sudden burst of flames to his face, but is otherwise fine apart from a raspy voice and singed mustache. So if you just pause it here, think about it, and then I'll move on to the next slide. So essentially all of them meet burns unit criteria except for the 26-year-old male with a deep dermal burn on his outer thigh. So why? So I've got the referral criteria here for you guys. So for the 1-month-old, they meet the criteria of extremes of age. For the pregnant lady, she meets the criteria of being pregnant, which is a referral. For the cement burn, that's technically a chemical burn. It's an alkalotic burn. And then for the chef who scalded their hands and inner thigh, that's a special area, and you've got to also rule out genitalia burn. And for the firefighter, they have an inhalation injury, so they have to be hospitalized and at least be observed. For that 26-year-old male, they didn't reach the criteria for an adult of 10%, and they didn't have full thickness burns as well. And just a point on that one before, the male, in all honesty, you would probably still seek some kind of medical advice for them. I'm just talking about whether they would be referred to, say, a burn center. So now a 34-year-old 70-kilogram man presents to ED in severe pain after burning both anterior thighs and the anterior right shin and foot from a campfire. This occurred 3 hours ago after rolling into a campfire. You assess the depth, and it's mixed superficial and deep dermal. So please calculate how much fluid they'll need over the next 24 hours. So just pause it, have a think about it, and then we'll move on. So for this one, you might get a question like this in exams, and they might not tell you how much they've burnt themselves. They'll just sort of describe it. And then what they're basically asking you to do is to now calculate their burns based on the rule of nines, because they haven't provided you with the Lundenbrauder chart. So we know that he's burnt both anterior thighs. So he's only burnt his left here. So that's 4.5% that we could estimate. And then he's burnt his right anterior thigh and his right anterior shin and foot. So there's 9% there, giving us 13.5%. So now if we calculate his 24-hour requirements, we've got a 70-kilogram man, so 13.5% times 70 times 4 mil gives us 3,780 mil over 24 hours. And I mentioned that he presented 3 hours after his burn, so we have 5 hours to give him 1,890 mil. Last question. So this one, are you able to define how deep this burn is? So pause it, have a look at it and think about it, and then I'll move on. So this is a deep partial thickness burn. And to be fair, it probably is full thickness in these areas, as if we follow our charts that I mentioned earlier, they are white there. But let's just run through our depth assessment tool. So we look at the burn. Is there epithelium? Well, this is epithelium here, and there clearly isn't any here, so no. We then move down. So is it slippery? Well, it's kind of hard to tell. We're not actually there, and the pictures don't really show this. But we can ask ourselves, well, is there a blister? So there is no blister. I agree that this bit is raised, but I wouldn't say that's a blister. And I also agree that on the outskirt, you can see a blister wall. But as I mentioned earlier, you should look sort of in the center area, because a burn will always go more superficial as you reach the edge. And as you can see, this is an epidermal burn here, and then it would go deep into a full thickness burn in here. So coming back to this, so is there a blister? No. And now it's easy. What color is it? Well, it's mostly red. So it's majority deep dermal burn. Though, like I said, I do agree there are some white bits, and going off our system, we would have to assume full thickness until proven otherwise. So that's the end of the lecture. And I've just got some resources, probably the most useful resources to you guys, especially if you're trying to cram the night before an exam, would be Up to Date and looking at this assessment and classification of burns injury tool, because this will cover pretty much everything you need to know about burns at your level, probably even a bit beyond it. In terms of skin anatomy and physiology, any anatomy and physiology book will do. I use Saladin's Anatomy and Physiology and really like that book, so by all means. And then there's these, if you want statistics, you can go and look at the Australian New Zealand Burns Association website or the Burns Registry of Australia and New Zealand. So thank you very much for listening, and best of luck with your exams.